Welcome to AO Trauma North America Fellows webinar. My name is Matt Camuso. I'm going to be the moderator for this evening's session that's entitled The Priorities and Pitfalls in the Management of the Polytrauma Patient. I am excited to introduce you to my good friends and colleagues and faculty members, Dr. Raymond Wright, who's a professor of orthopedic surgery and the director of his fellowship there in Kentucky, in Lexington. Really facile surgeon and expert, especially around the pelvis and acetabulum. He's going to talk about some of his tips and tricks for managing difficult pelvic ring injuries. And then my idol, Steve Warner, who did everything that I always wanted to do as a young athlete, including row in a world championship. Steve's a young guy, assistant professor of orthopedics down in Houston, and he's going to talk to us a bit about indications and techniques for algorithms in taking care of difficult trauma patients. I'm just the moderator. I'm going to learn a lot from these guys, I hope, tonight, and I hope you guys all do as well. These are some of the required slides that we have to give. AO North America, as you all know and benefit from, is a independent surgical specialty society, which is dedicated to education. We don't endorse any specific products, and anything that you see during this webinar is really just for teaching purposes and demonstration. You all are pretty facile with Zoom. Your microphones have been muted and your cameras turned off, but the Q&A box is open. And so if you have questions, you won't use the chat box. Instead, you'll use the Q&A box, and we'll try our best to keep track of those and answer those for you, either in an answer box or ask that question, especially if it's a good one, live to the faculty members as we go through, and we'll try our best to get to all your questions. The chat box will just be for the faculty and staff. Most of all, I want you guys to participate. So, grab a beverage, your favorite beverage of choice, as we all have, and sit back and get involved. All right. So at the end of this session, we really want you to be able to appreciate the appropriate strategies for management of pelvic fractures, and including indications for sheathing, external fixation, resuscitation screws, and early definitive management of pelvic ring injuries. We want you also to be able to think about and maybe develop your own algorithm for prioritizing the timing and sequencing of patients with multiple skeletal injuries, with an appreciation for the injury patterns that present themselves and patients' physiologic conditions. And since they're my cases, we're going to highlight lots of clinical situations to avoid, because God knows I've made lots of mistakes, and we're going to go through some of those things tonight so that you don't make the same ones that I did. Of course, this is a fellows webinar, and so we have some assumptions. This isn't a basic or an advanced course. You all have a lot of knowledge already as a foundation. You already understand the priorities of trauma management: first life, and then limb, and then certainly we aim to limit disability. You all are facile with maneuvers that can save patients' lives and limbs, and so we won't go through those in detail. You already know the difference between early total care and damage control orthopedics, but we're going to sort of delve a little bit deeper into why one would choose one over the other. And then finally, and it can't be underemphasized or overemphasized, you got to play well with others. All of this happens as a team. None of this care happens in a vacuum, and you've got to be able to work well with other members of the trauma team to be able to do well for your patient. And hopefully we'll show at least a couple successes that happen because of that. So we're already 5 minutes into it, which is perfect. That's my introduction. I'm going to give way here to Dr. Raymond Wright, who's going to talk to us about acute management of pelvic ring disruptions. He's then going to be followed by Steve Warner, who's going to talk to us about the algorithm for patients with multiple injuries, including timing and sequencing. And then we'll switch back to us, and we'll go through 3 or 4 cases to highlight those issues and try to answer all of your questions as we go through. All right. Sound good? All right, Raymond. Hopefully I just stop sharing and hand it over to you, brother.
And I think I just started. All right. Well, thanks for having me. It's an honor to be part of the team, and And good evening, everybody. And I'd like to try to uh, set the stage for you a little bit to give you some uh, tips and tricks for acute management of pelvic ring injuries. When we were planning this webinar, Dr. Camuso said to me, he's like, I just need you to teach him everything about operating the pelvis in 10 minutes. And I'm like, no problem. We got this, And so, well, it's an awful broad brush that we're painting with. And so really what I want to talk to you about is we'll discuss indications very broadly on when to operate and maybe even as importantly, when not to operate, and highlight just a couple of techniques that are maybe some of my favorites that can be used acutely in resuscitative arenas or as definitive care, and we'll provide just a couple of different examples. Since you are fellows, or some of you I see are on faculty that are faculty members that are on this webinar, I'm going to assume that you know that the assessment of the pelvic ring injury patient begins in the emergency department, and a lot of times, and I'd say every time, that we as orthopedic providers can be there and provide a unique insight and skill for resuscitation. As Matt had pointed out, that this is you have to play well with others, and this is a multidisciplinary care situation for the ultimate and good outcome for your patient. Instability in pelvic ring injuries may be subtle, and I hope that you've seen that in your fellowship, or if you've noticed that as a faculty member, that it can be subtle, and patients can die from these injuries. We can employ, speaking of being uniquely qualified, we can employ circumferential anti-shock sheeting, which can be a very powerful tool for reduction of pelvic ring injuries like we see in this patient here. And these are things that your general surgery colleagues will not think about. You can also talk about external fixation as a resuscitative adjunct. This is great for reduction. It's good for especially anterior stability. It can be definitive or provisional. This is something you should place slowly. The pin placement requires considerable skill and understanding of radiographic parameters. This is not something that you throw on emergently in the emergency department. We used to get that request when I was a resident, and those were sort of in the dark ages. But sometimes this can be a second phase if you cut out working portals in your sheet in a resuscitative situation, where you can place these pins and even place iliosacral screws if you cut some working portals into your sheet like we do in this particular patient example. Also, skeletal traction. Don't forget skeletal traction as a resuscitative adjunct, as well as a help as for definitive fixation in the operating room. This can prevent a reduced deformity, especially a cranially displaced hemipelvis and posteriorly displaced hemipelvis, as we see quite frequently. Great intraoperative adjunct. The only contraindication I can think about is the occasional caudal and anteriorly displaced hemipelvis, which is rarely seen because they we think in theory shear off great vessels and cause likely death at the scene. But I've seen that a couple of times in my career, and maybe the only contraindication I can think of for skeletal traction. Your treatment options for pelvic fractures really fall into two categories, or operative and non-operative care. And non-operative care is great for the so-called Lc1 fracture. The so-called Lc1 fracture is usually a lower energy lateral compression style injury, where patients will get a sacral buccal injury, like you see right here in this extraforaminal region, peripheral to the sacral nerve root tunnels. And what you can see on the axial CT scan is minimal, if any, displacement of the overall pelvic ring. Generally, these patients do very well with non-operative care, and I'll usually let them weight bear as tolerated, especially when these patients have minimal or almost no perceivable displacement on radiographs and CAT scan. Occasionally, you'll get isolated anterior direct injuries to the superior and inferior rami without any posterior injury, like we see in this patient here. And if something like that happens, where there's no injury to the posterior pelvic ring in general, it's very acceptable to treat these non-operatively, as are some iliac fractures, some fractures of the peripheral ilium, if displacement is not too great. And what is too great is a little bit subjective, but these by and large can be treated non-operatively as well. what we tend to operate are unstable pelvic ring fractures, and stability assessment can sometimes be obvious on plain films. This is one, if the ophthalmology resident can see that there's a pelvic fracture in general, it's probably an unstable pelvic ring injury. But sometimes instability is not as clear as you may think. And so, like in this patient here who has overall minimal displacement, you can see anterior pelvic ring injury is pretty clear. And if you scour the X-ray, you can see sacral fracture through this transforaminal zone somewhat. And these are patients that I'll try to mobilize. But if you want to really chase down disease or really seek disease, sometimes a stress radiograph in these patients can be very useful for demonstrating occult instability. You take the patient to the operating room, place him or her supine on an operating room table, and get a little skeletal paralysis. And on an inlet view with just a little bit of laterally directed force, which is really rather difficult to quantify. But if you can demonstrate gross instability through these regions, oftentimes this is an indicator of overall pelvic ring stability, and in my mind, an indication to operate these patients, especially if pain is too great to allow for the patient to be mobile. So operative care, in my mind, is reserved for unstable fractures, and these can be done both percutaneously or open, or a combination of both. And so to tell you when to operate and where to start is, gosh, that's a whole year to get going, and maybe even a whole career to truly understand. But my basic guidelines for when I'm operating the pelvic ring are to operate which segments are stable. I'll find whatever stable foundation is present or available to build back unstable segment or unstable segments. And so once those are identified and the type of instability is identified, then I can begin to develop a strategy to reduce deformity, be it rotational, vertical, or both. And then I like to secure all points of instability if possible, meaning if there are points of instability that are both in the anterior and the posterior pelvic ring, I'd like to secure all of those if possible in the patients, if soft tissues will allow, if bony anatomy will allow. And this really goes back to some very early biomechanical data that came out of Harborview in the late 80s and early 90s. And so a classic example of an unstable pelvic ring injury here, we have a symphyseal disruption in a patient that presented to our institution I actually just saw this guy a couple of weeks ago, and it was his year follow-up, and he is he's an interesting fella. Was in a motorcycle crash and is a motorcycle enthusiast, and he just couldn't wait to get back on his motorcycle. But here's a gentleman who presented to our institution. What I see immediately is disruption of the symphysis pubis. I can also see this patient comes in a pelvic binder, and he's got a bladder that's starting to fill up, and they haven't put a Foley catheter in him yet. And beyond that, I think it's a little challenging to tell. At our institution, when people show up wrapped up, there's the old adage of you should open every present that's sent to you. And so we opened up this present and just to check his skin and his soft tissues, and thorough evaluation of the skin, especially looking at patients in areas that you might not want to be looked at. But I think it's important to define or identify covert open injuries, or maybe sometimes not so covert open injuries. But we took him out of his binder. We're big fans of anti-shock sheeting, and so we put him back in his sheet and got a new radiograph, and you can see the persistent disruption of the symphysis pubis. But what is also sticking out here is we have disruption of this left-sided sacroiliac joint as well. Just visualizing this on plain films, bladder is still full, and we really need to get a Foley catheter in this guy pretty quick. And what you'll notice somewhat on his AP radiographs is he has a dysmorphic upper sacral segment that was really rather small. We'll see this a little bit better on his outlet views. Axial CT scan through the second sacral segment demonstrates that he has a wide open segment for screw fixation, if we choose to use screw fixation, and a subtle but real widening of the sacroiliac joint anteriorly. This was a CT scan, oddly enough, that was still taken in the patient's binder. These are at least just a quick overview of the bony things that I see. He was on hospital day 2. We took him to the operating room and checked his hemodynamics carefully as we removed his pelvic anti-shock sheet. And you see how displaced this symphysis pubis is, and really goes to as a testament to the amount of energy that went through this patient's pelvis. And this is probably closer to where the patient's pelvis lay when he was originally injured. We had done an internal rotation maneuver and taped the patient's toes together and taped his thighs together, which led us to get a little bit more improvement in this area. And he was a really rather large fellow, and so I tried to do as much as I could before we opened him. And so in this case, for symphyseal disruptions, I like to use an open exposure, elevate the rectus abdominis to the bilateral pubic tubercles, and a well-positioned surface clamp gave us, I think, acceptable reduction. And once that was reduced and a plate applied anteriorly, just as I'd said before about securing all potential points of instability, once the front is fixed, I really like to fix the back. And this may be still controversial in some segments. I think there's reasonable literature to suggest that if you fix the back in addition to the front in these rotationally unstable or ostensibly rotationally unstable injuries, that your risk of failure of your anterior fixation is lowered. Your risk of failure of your overall construct is lowered, so long as you can place screws safely. We place first a partially threaded sacral or iliosacral screw in transiliac transsacral fashion to achieve compression through the sacroiliac joint, and then backed it up with a fully threaded screw because his second sacral segment nerve root tunnel was so large. Post-operative exam, I think, demonstrates some pretty reasonable alignment. And here on his outlet view, you can see all the markers of sacral dysmorphism that we talk about in the literature. We got our mammillary processes, our persistent disc space, our tautic appearing nerve root tunnels, and anterior and upsloping alar regions. And so this is just a really common fracture pattern, and maybe sort of my favorite tactic. And going back to my original strategy, really just overall strategy, is identifying this whole segment, including the patient's right hemipelvis and sacrum, is the stable segment over on this area, and this area is being an unstable segment, and rotationally so. And so that allowed me to plan for a proper clamp application and insertion of implants. This is just a different kind of case that was unstable, rather young man that was involved in he was a driver and was T-boned from the driver's side. He was seen, I think, by our weekend team and deemed to be stable. It's just a lateral compression injury. It's just an Lc1 is what was said over the weekend, and he's stable and he'll be fine, and let him walk. Well, he just couldn't walk, and it's pretty unusual and pretty rare for a 17-year-old kid not to be able to get up and walk if it's truly an unstable injury. But what I see that's pretty clear is disruption and almost, I'm hesitant to say fixed internal rotation of this, but he's got an internal rotation, this hemipelvis, that is subtle but real, and it's a little bit hard on this AP radiograph to discern his sacral fracture anteriorly. Inlet view and outlet view demonstrates, or sort of faux outlet view, Kentucky outlet view, I guess. But anyhow, so that demonstrates his deformity, which is not much. But again, I think his bigger issue was pain. I think on this inlet view, you can see a little bit better this extraforaminal sacral fracture that appears to me to be complete through this injury. And we see that very same issue here is not only is it complete, but this fracture line exits right about at the level of the L5-S1 facet. And then what you can't appreciate on the plane films is this iliac injury posteriorly. Joe Borelli has a very, very nice review on crescent fracture dislocations. And, I think although small, I think this is a real crescent fracture. And I think that this is something that that is a marker of real instability, that combined with this sacral crush that goes all the way through the sacrum to the back. And it makes you think that, much like in the last patient where the deformity at the time of injury was probably much greater than what we saw, I gather the same thing is true about this young man. And so now I can map out this whole side as being my stable side. and this being my unstable side over in this direction. And so it just so happens that externally rotating these patients can be very nicely done through a percutaneous maneuver, which is maybe one of my favorite maneuvers. And the inspiration comes from Chip Rout, who's now at Houston, who he tells a great story about a spine surgeon who'd inspired him to do this like 20 years ago. And we're doing it now, and we all think that we're hot stuff and we're new and innovative, but this was stuff that was being done by him a long, long time ago. But so reasonable correction of the patient's deformity through this mid-ramus fracture, again, fixing both the posterior and anterior points of fixation. I like to use solid screws whenever possible, and he's a 17-year-old boy, and by virtue of that, I think prone to misbehavior. And so we just sort of backed him up with as much fixation as we could in the anterior pelvic ring, removed our femoral distractor anteriorly, and found there to be stability post-operatively, and I think very good radiographic result, and very reasonably clinically as well. He got up like in the PACU and got up and moved around after 2 days of laying in the hospital. And so these are just
those
a couple
4 or 5 screws in the front there, Ray?
Yes, sir.
4 or 5s in the front?
4 or 5s in the front. 4 or 5s in the front. And my Symphysis reps, I have reps that give me blunt tip screws. If you look real careful, they're blunt tip screws, and I think that's pretty important for navigating these. And so they hate me because instead of buying $30 screws, I buy $12 screws from them, and they just, so anyhow. So to summarize, indications I think to operate are really instability, and that's the inability to resist deformation under physiologic force. And what's more important to that is that if there's hemodynamic instability, it can be due to the pelvis, but only if that pelvis is truly unstable. And so stable segments, stable pelvises in general don't lead to hemodynamic instability, but unstable ones do. Sometimes this instability is subtle and you need to seek it out. The techniques are multiple, and I think 10 to 15 minutes is insufficient to give you them all, but just understand that you can have open exposures. You can use, I like screws a lot, but you can use plates, or you can use external fixation, even if it's an open exposure if you want to, or a little bit of both. And I hope these examples will help you in your clinical career and sort of spur your thought processes when it comes to fixing these in the future. Thanks for having me, and thanks for your time.
Ray, that's awesome. Thank you. Tons of pearls in there, so many pearls that people are just frantically writing them all down and not asking any questions in the Q&A box, and that's okay. Yeah. But we're going to expect more from them later. My favorite part about that, well, there's 2 things. One is that image that you show of the sheeted pelvis through which you make working portals. Is that like a once in a year thing that you do, or is that like once a month or once a week? How often are you doing that? Because that's a pretty cool technique.
Yeah. It's probably 2 or 3 times a year. Cool. And the last couple of years has been, it's been with the pandemic and stuff, it's been a little sparse, but before that, it was 2 or 3 times a year. And that's a great trick it's a great technique rather, if you need to do a resuscitative iliosacral screw, excuse me, or if you need to apply an external fixation device, especially in a resuscitative situation, that sheet can help hold your pelvic ring in a reasonable position as you apply your resuscitative, more definitive fixation.
Yeah, we've all been in that situation where we had a sheet on, right, and it looks great in your post-sheeting radiographs, and then you bring them into the OR, position them, take the sheet off, and then whoa, things are a lot different. And so it's nice to be able to take advantage of the sheet if you can. Very, very cool. The other thing that I loved is that you said was open up every present sent to you. That's going to be sage advice here coming up in a couple cases that we get to here a little bit later. So Awesome job, Ray. Thank you very much.
Thank you, Matt.
Steve?
Yeah, Ray, one other question that came up in the Q&A box. Is there a maximum time frame you suggest to keeping a resuscitative sheet on or a binder on?
Yeah, that's a great question, because people, and rightfully so, I'm gonna frame my answer in kind of a sort of funny, sarcastic, maybe ironic way to help you remember it. At our institution, we're blessed in that we've got people that that like to do these, and we can really get to these rather quickly. But a lot of times our general surgery colleagues or nursing colleagues will get, what's the word I'm looking for? Vigilant to the point of being argumentative about the circumferential shock sheet. Agitated is a great word. And so I try to put it in the context of, like, I understand you're worried about the soft tissues, but this kid got hit by a car. Like, this is like 800 thread count cotton, you know, like it's okay. But to that end, for you to be able to say that, I think you need to be putting these on very smoothly. I think you need to be putting them on in a wrinkle-free fashion, and strategically. So Route from 2001, I think it's 2001, has a nice technique article on how to do this, you know, and it takes 2, sometimes 3 practitioners to do this, and make it look like a nice, smooth sheet. Just throwing it on there and tying a knot will make a wrinkled mess and can give you some bed sores and stuff. But I don't have a maximum time frame. I do think it's smart to consider the soft tissues, but generally we're getting these done couple, 3 days at the most at our institution.
So certainly appreciate the interactions here, and feel free to type in questions in that Q&A box as we move forward and make this as interactive as possible. So as we go through this discussion, we are going to follow along a patient who's a 16-year-old female, came in after a high-speed motor vehicle collision with multiple traumatic injuries, and she's going to help us kind of guide through the discussion of an algorithm for managing a polytrauma patient. She has these injury x-rays as shown here, and while the pelvis is a closed injury, the other injuries are open fractures, and so that may influence the acuity of these injuries and influence the sequencing and so forth. And so as we go through this case, as you guys start to reflect on what you would do with a patient with these type of injuries, some questions that maybe come to your head are what other injuries they may have, both orthopedic and non-orthopedic, what needs treatment during the first operation, how much surgery is okay to do during that initial operation, how do you sequence these types of injuries, and then what about timing for other definitive fixation procedures. So as we go through this, we hope to be able to address some of these objectives and understand why and when polytrauma patients may need temporizing. We're going to assess some factors that may influence their treatment. And our goal is to really develop an algorithm for managing these polytrauma patients. So first and foremost, why does it matter? Why put all this thought into what surgeries to do, when to do them, how to do them, what sequence to do? Well, the overall goal is to really reduce complications in these polytrauma patients. And we know that in these polytrauma patients, there's this trimodal distribution of death as they enter in the emergency room until the several weeks after surgery. And if we look at the causes of mortality in these polytrauma patients, as orthopedic traumatologists, we can certainly play a significant role in minimizing their mortality, especially in the first few hours after injury, and even several weeks after, by managing pelvis fractures, long bone injuries, and infection that can lead to sepsis and multi-organ failure. And if we manage these injuries correctly, we can really minimize their complications and mortality from these injuries. And so if we look at patients like this with these types of injuries and this polytrauma status, to minimize these complications and to minimize mortality, what is the best strategy to do this? I think it's always important to go back briefly into history and know where we came from and how we got to where we are now. And so this is a classic study by Dr. Bone in the 1980s, where he looked at early versus delayed treatment of femoral shaft fractures. And what he showed is that early treatment has improved outcomes, in this algorithm of treating injuries early on, or what's called early total care, was then favored in these types of patients. And then subsequently, there was a pendulum swing to the other side, where we noticed that some patients with these polytrauma injuries had worse outcomes when we did a large amount of surgery fixing their orthopedic injuries early in their postoperative course. And so this subsequent study then showed that temporizing external fixer had improved outcomes in these polytrauma patients. And this algorithm was then termed the damage control orthopedics. And then as time progressed and more and more studies were done on this, there was the thought that some patients did well with early total care, some patients did better with the damage control orthopedics, and these algorithms were then starting to be developed, where Based upon the patient's clinical condition, if they were stable, they were amenable to early total care and did well. If they were unstable, then a damage control orthopedics algorithm would be better and they had better outcomes and less mortality. I think that's all and well until we get to the borderline patients where lots of factors are involved and they may do better with early total care and some may do better with damage control. And it's these mid-ground patients, these middle of the road patients that are borderline clinical condition that really have challenges with determining what to do in their early resuscitation course. And so as these two general theories of how to deal with polytrauma patients at early total care and the damage control orthopedics began to develop, these meshed into early appropriate care treatment algorithms to manage these polytrauma patients. So it all sounds great, early appropriate care, but what is appropriate? What does that mean? It sounds great, but what does it actually mean when you're trying to manage these polytrauma patients? If you look at this algorithm that was developed by the Hanover group in the early 2000s, you can see what really stems off of how to treat these patients is their clinical condition. You can categorize these patients into stable, borderline, unstable, or in extremis. And so that's great. So how do we know what the patient's clinical condition is, which will then dictate what we do for these patients with their multiple orthopedic injuries? And so there are certain factors that we can use to help with this. There are patient factors as they come in, they have an age, they have a mechanism of injury, they have comorbidities, and then they have their injuries, including unstable pelvic ring injuries, as we saw Dr. Wright present on. There's femur fractures, which we know influence their outcomes in polytrauma status. They have open fractures and they have other injuries in the head, chest, and abdomen. And all these injuries and all these characteristics are present when they hit the door in the emergency room. And so one way to think about this is that these are the relatively static factors in these patients. These are known and they will not change once the patient hits the door. Their injuries, their age, their mechanism, their comorbidities are all set by the time they hit the door. So these are all static factors in these borderline patients. The other component is their dynamic factors. So as these patients are undergoing active resuscitation, they have a very dynamic physiologic status that's reflected in their respiratory status, their transfusion requirement, their acidosis level, and the coagulopathy. So all these factors, both static and dynamic, as these patients are undergoing resuscitation and being evaluated, have a role determining what the best course of action is in managing the orthopedic injuries. So now how in practice do we get to assess these patients? And lots of different ways to do this. This is one chart that starts to assimilate some of this information. There's a ton of information in these charts. And so it's very difficult when you have a patient come in tomorrow with this polytrauma status. How do you categorize this patient into a stable, borderline, unstable clinical condition? Very hard to do. Most patients aren't going to be able to put into one of these buckets. But I think what's helpful and what's been borne out over and over in the literature through multiple decades is that lactate levels can be very important in this. And certain cutoffs have been used, whether it's 2.5 or 4 millimoles per liter. The absolute number is one factor, but I think more importantly is there trends in lactate levels. Are they climbing? Are they decreasing? Are they stable? And so these lactate levels are really important. I think one of the most important factors when you're assessing the clinical condition of a patient, deciding whether or not they need some sort of damage control maneuver or more early total care or early appropriate care. So we talked about why and when polytrauma patients need temporizing. We talked a bit about the factors that influence what to do with them. But do we have an algorithm? Do we have an algorithm? Once a patient comes to the ER, what do we do with these polytrauma patients? And so we had a glimpse of one from the early 2000s, which starts to get at an algorithm of what to do with these patients. And based upon their clinical condition, do they get early total care or damage control orthopedics? And this has evolved over time. This is one of the more recent algorithms that was published within the past few years. And along the similar lines, you assess the patient of their clinical status and if they're borderline, unstable, or in extremis. And based upon that, they get a resuscitation and then either some sort of safe definitive surgery along the lines of an early appropriate care protocol or damage control orthopedics. And then they undergo reassessments over time to be able to determine how to time the rest of their definitive management. So this all sounds great until you have to put into practice. And then you certainly realize the challenges of an algorithm with this, which are several, but two main challenges, I think, with an algorithm like this in a polytrauma patient is that these definitions are really imprecise. What makes a borderline or unstable patient, which is then going to dictate what you do, is an imprecise definition based upon lots of factors. and also the permutations that you can imagine with all of these polytrauma patients, their injury characteristics, what types of injuries they have, as well as their physiologic status. The permutations are essentially endless. And so how to place them in this protocol can be challenging. That being said, there are certainly key factors that I think can be used with this algorithm as a framework in order to manage a polytrauma patient. And we'll kind of go through a few of these key factors, which I think will help guide the management of these polytrauma patients using this algorithm. And so certainly one of those is the injury qualities. And we talk about the injuries, we kind of like to characterize and classify injuries in orthopedics. Also important to know the qualities of the injuries. An open tibia fracture can be a small traumatic puncture wound of a simple transverse fracture, or it can be an open degloving injury with extensive contamination. Those are very different injuries. Likewise, pelvis fractures can be pelvis fractures that are stable, unstable. Unstable pelvic fractures can be volume expanding pelvic ring injuries, which have a significant concern for hemodynamic instability. So pelvic fractures come in many different forms as well. So knowing the injury qualities and what they are, not just a pelvic fracture, but what kind of pelvic fracture can be really important. And that goes into your primary assessment of the patient when they hit the emergency room. Along the lines, another key factor in implementing an algorithm like this for a polytrauma patient is serial assessments. And so you're assessing this patient obviously when they get to the emergency room, but those assessments are going to repeat hour after hour and day after day as this patient undergoes resuscitation. That's a critical point in assessing when the patient is ready to go to the operating room, what type of surgeries they're going to be amenable to have. A third thing, as we mentioned, as this patient is undergoing resuscitation and their assessment is undergoing, lactate values are really important. And those help us not only have a baseline of their end tissue perfusion and acidosis level, but it also gives us a real-time value of how that patient is being resuscitated, not only before we get to the operating room, but also intraoperatively. As we're going through procedures, we can have anesthesia draw a lactate value and see how they're managing their physiologic status. And then lastly, as was mentioned multiple times, coordination with other teams is really, really important in managing these polytrauma patients. This comes into play during their initial resuscitation before the operating room, immediately after the operating room, and then the day subsequent as they're being reassessed for other definitive fixations, coordinating with the general surgeon team, the neurosurgery team, and other clinical and surgical teams is critical in order to optimize care of these patients. So I think with this algorithm in place, while it does have flaws, certainly these key factors and remembering what's important in dealing with these patients can make this useful in order to optimize care for these patients. So getting back to our 16-year-old female high-speed MVC, you can see here her injuries, including this unstable pelvic ring injury, open femur, contralateral open tibia, as well as the open elbow fracture dislocation. And other questions you may want to know with her polytrauma status is what other injuries she has. So she has a stable splenic laceration that did not require any exploratory laparotomy. She had a small but stable subdural hematoma, as well as a right pneumothorax that was treated with a chest tube. And her current lactate after initial resuscitation is 4, which is borderline for what may some consider for being able to proceed the operating for some sort of definitive treatment. So with this, she's able to go to the operating room. And then your decision is what to do with the pelvis, what type of treatment to do with the long bone injuries, with the open fractures, and how to proceed with her. And this will be great discussion points for cases that we're about to discuss. But what was done with her case was definitive fixation of her pelvis with an open reduction of the anterior pelvic ring, and then percutaneous fixation of the bilateral superior rami, as well as the posterior pelvic ring. And then debridement irrigations of her open fractures with provisional stabilization of her long bone injuries, as well as reduction of her elbow fracture dislocation. And this was what was done on day 1, considering her clinical status, what injury she has, to try to minimize any complications she has and maximize her longer term outcomes. And here she is at 6 months down the road with an uneventful recovery from these injuries. So take home points, considering all this, first, you want to recognize those factors, both the static factors the patient hits the operating room, hits the emergency room with, as well as those dynamic factors which the patient has as they're undergoing resuscitative measures. Those are really critical in determining what the patient is able to have during that first day or that first operation for their orthopedic injuries. as was mentioned multiple times, you have to function well within the care team. Having a very good working relationship with the general surgeon, trauma team is critical, as well as the neurosurgery team and other surgical teams taking care of these patients. Lastly, adhering to a general algorithm with continual reevaluations or assessment of the patient as they're being resuscitated is critical to know what the patient's physiologic status is and what trajectory they're going into to be able to determine what surgeries they can sustain. So that's the overall overview of an algorithm for polytrauma patient. And now I think we're going to get into some cases with Dr. Camuso. So happy to answer any questions as well.
Thanks, Steve. That was awesome. It's come a long way since when I was in training. I still was sort of going by that original algorithm that was written by the Hanover group that was really quite vague and difficult to understand. Your new algorithm, written by the same authors, I think, for the most part, sheds a little bit more light on it. When I was in training, we were taught that if someone was so sick that they needed damage control, that the time to do their definitive surgery really had to be delayed, right? Like if you framed them on day one, really the worst time to operate on them, according to the theory at the time, was between day 2 and 5, because they were primed, right? Their inflammatory status was just totally jacked up, and any insult, any reaming of canals, any long surgeries would really put them over the edge. Do we still believe that to be true, or is it more that we need to sort of each day determine what their individual daily ability to tolerate a big surgery is?
I think much the former. I think each patient comes with a different clinical scenario. So they have a specific algorithm of between day 2 and 5, that second hit phenomenon is too at risk to do any sort of major orthopedic surgery. I think is challenging to go off of directly. I think you have to look at each situation and why they may not be a candidate, whether it's continual hemodynamic instability, or if it's acidosis, or if it's respiratory complications, is it a head injury? And each of those reasons will dictate the timing of it. Sometimes the head injuries are precluding any surgery for a few days. Sometimes the general surgeon just want a little more resuscitation for the next couple hours, and they can be cleared to go the next day. And so all those factors come into play. And I think you have to be flexible with your timing of those surgeries.
Yeah, constantly reevaluating, like you said, and looking at trends, right? There is one question.
Yeah, I was
go
going to
ahead,
say,
Ray.
Steve, you know, from the, just to summarize a question from the Q&A boxes along the same lines of that discussion, and I'm paraphrasing the question, but how at your institution do you manage patients with traumatic brain injuries when neurosurgery is maybe not comfortable with early total care or damage control at times? It seems that this participant has patients that are injured with bad head injuries, and physiologically otherwise they seem to be ready to go to the operating room, but the neurosurgeons put the stop to it. How do you broach that subject, or how do you navigate that?
Yeah, it's a great question that comes up not infrequently, and I think having a direct conversation with the neurosurgeons about what their concerns are and what you would be looking to do is important. I think things that they may not be aware of is that you can do most lower extremity surgeries with the head of the bed elevated to decrease the ICPs. And they may not be aware of that. They're thinking that you're going to go supine and not be able to do that. And so I think that kind of direct communication with them is important. And then the length of the surgery is also really important, and being honest about that. If they say you're cleared for 60 minutes of surgery, do 60 minutes or less of surgery. Do not do 61 minutes of surgery. Because you will then develop trust in them, they'll develop the trust in you, and there'll be a much better relationship moving forward. If you go in and do 3 hours of surgery, if they allow you 60 minutes, then it's going to be pretty tough to allow them to have another surgery down the road in a similar situation. So those are the two things that I think I would recommend in that situation.
It's kind of amazing what problems get solved with just like a little direct communication with folks, you know, and it, like, to the point of educating, you know, where you can just ask, hey, what's your fear? And they say, well, you're going to put this patient prone. And I'm like, no, we're not, you know, and it's just really not, you know, and oh, okay, well, in that case, have at it, you know. And so sometimes especially in our society of texting and instant messaging and epic chats and all that stuff, sometimes a little face to face and good human interaction is nice.
And the trust grows when you do what you said, and then the head injury gets better faster.
Yep.
Right. Like when you provide stability to that long bone, and then their ICPs go down, and they realize, oh, maybe there is a role in stabilizing those long bone fractures that are constantly creating this feedback loop to the brain that are jacking up the ICP. So great talk, Steve, and summary, and I appreciate your doing that line show work for us. So I figured that we would get through a couple cases here. We have officially till 9:30, although we've been asked to try to get off by sometime after 9 o'clock. But I want to get through a couple cases here. So let's get after it. So this first case is going to focus on the pelvis. So Ray, you'll be in the crosshairs here, but certainly Steve, we're going to get you involved. This gentleman was at work, and he got crushed between two trucks and was pinned in between those trucks for about 20 minutes. And once they were able to extricate him from between the two vehicles, there was just a pool of blood on the road, and he was pretty he was in bad shape. So he was taken emergently to the emergency room where his airway was intubated because he was really having trouble staying awake. He was tachycardic and hypotensive, and he was noted to have a very large wound in his groin with ongoing hemorrhage. He got a quick, typical emergency room AP pelvis X-ray here, which isn't ideal for classification, but certainly we all can see that there's a problem here, and a very rapid abdominal fast examination was positive. So a lot going on. You can imagine there's a frantic emergency room here right now. What is the next move? Do they take them to the CT scan? Do they go to the operating room? What can we do here at this time, Ray, to help out the team?
Oh yeah, that's a great question, and I think that all starts with showing up. In my talk, as part of being a resuscitator, you have to be there if you can be a resuscitator, and even if you're a big bad fellow now, you can show up and help to resuscitate from time to time. And in my mind, when I see that, besides airway protection, the insertion of two peripheral large bore IVs, when I see what is ostensibly a ring expanding injury like you have in this AP hemipelvis hemifemur radiograph, I think circumferential anti-shock sheet to help. I don't think CAT scan right now is the answer, especially if this guy is dying. Before you're applying your sheet, I think this is a good time. It takes less than like 3 seconds to take a look in this guy's groin where there may be open wounds, because the wounds that will kill people with injury, this is where they typically are. So get on a sterile glove, take a quick look around, make sure there's two peripheral large bore IVs to get a circumferential anti-shock sheet on the patient. And if there's any other data to suggest that he's got cranial instability of one hemipelvis versus the other, traction pin might be nice too.
I'm reminded by the words that my mentor used to say. He'd say, plug them up, wrap them up, warm them up, fill them up, and on, right? So
Yep.
So those first four things you can do right there in the emergency room, right? His groin is bleeding.
Yep.
And part of that investigation is to see if that groin wound communicates with his with his pelvis, and then you can just plug that up. Yep. Sheet, like you said, get them warm, and IVs, and we can help with at least 3 of those 4 things.
Yep. In terms of that packing up, keep a Kerlix in your. If I don't think I said plug them up, but I meant to, and I didn't, and I was just so excited for the moment. But so having a Kerlix or 2 in your white coat pocket, because y'all don't carry stethoscopes anymore. Having a Kerlix or 2 in there is great, because when you shove up one Kerlix, you can tie another one on in there, and that way laps or tapes or gauze doesn't get lost. And so when you see that open wound, pack, wrap, warm them up.
So they're going rapidly to the operating room. Steve, anything you want to tell the OR that you might need during this episode? They're going to do a laparotomy, but it's likely that they're going to ask for your help. What are you telling the OR to get ready with?
Yeah, I think this would be great to have an external fixator in the room and open, ready to go for them. You know, I think this is going to create the dilemma of when they bring them up to the operating room, you have your sheet, the pelvis is nicely closed down to reduce the true volume of the pelvis, and they're going to want to take that sheet right off when they get to the operating room. And so options you have are either putting a sheet lower down in the thighs, which will still have some effect at reducing that true pelvic volume, or putting an anterior external fixator on as well to help reduce that pelvic volume. But something to help reduce that true pelvic volume to minimize bleeding in this patient will be important as they do their exploratory laparotomy.
If
Some
I
things
may,
that we, yeah,
sorry.
go ahead.
Sometimes a thing to ask them for too that can be a stopper at our institution is ask them to put them on a radiolucent table.
Yes.
It's a real mood breaker when you go up there and they're like, we're ready for you to put it on the X-Fix, and they're on a Skytron and you're like, dang, you know, and so it doesn't take much to facilitate that communication.
Yeah, you read my mind. That's exactly where I was going. It seems like just a simple thing and it happens automatically, but they're not thinking what you're thinking. So just they don't care what table they're operating on. If it's level, they're good. So if it's a radiolucent level table, that's good. So he ends up in the operating room with an emergent laparotomy. He's got a splenic laceration that comes out, and during that laparotomy, they're looking low and they see a large pelvic hematoma, as you'd expect. They also explore his groin and repair his femoral vein and ligate his profunda. But he's still doing poorly. He's got a lot of blood. He's got some factors. He's got some whole blood, because back in those days, this was a while ago, we were using whole blood a lot. And he still is needing vasopressors to maintain his blood pressure. So his toes are taped together. They wouldn't let us put a sheet on, but they want to know, what we can do to help. So I think you guys already sort of started talking about that. He's still hemodynamically unstable. At this stage, he's not got anything in his chest. They've controlled his abdominal bleeding. Most likely source now is from his pelvis. And so what can we do? And what would you do in this case? Take us through, Ray, exactly how you might apply this frame.
Yeah. So if they're finished with their laparotomy and I'm able to, a lot of times I think it's really nice to apply while you're in the operating room. You can use your draw sheet, if it's a well-placed draw sheet, as a circumferential anti-shock sheet. And I like to put that on there because and get reduction with a fluoro confirmation of it, and whatever reduction you get, I think is great. But what I think you want to monitor more of their hemodynamics at this point, and monitor how that's going, because that can dictate your urgency, I think, somewhat. And that if you get a fluoro unit in this situation, it can give you an idea of their overall alignment, because so far as I see, I don't have a whole lot of data on this patient's injury. I mean, we got this, like I said, ostensibly open. Okay, great. So now we have our sacroiliac joint, which is completely displaced, and it looks like on both sides, if I'm looking at your images.
That's what I was trying to image.
Yeah.
We don't have any plain films of it, but that's
right.
Yeah, that's both sides, posterior SI joints, both gone. Yep.
Right. And so when I see something like that, I like sheet and not frame immediately. And I say that because if you close down the front with a frame, where a frame is very effective, a lot of times you can widen the posterior ring and make that even worse. And so if I see something like that with this guy's hemodynamic parameters that are so bad, I like circumferential anti-shock sheet, cut working portals where I would put in iliosacral screws and do some resuscitative iliosacral screw fixation for his posterior pelvic ring.
I love that.
Ray, are you putting a frame and then on after that, or are you leaving a sheet on, or what are you doing after that?
Usually putting it kind of depends on what their anterior injury is. But if it's a ring expanding injury through symphysis, I would tend to probably put a frame on, but it kind of depends. If my pin insertion is going to is going to be in the way of maybe a definitive ilioinguinal incision, I'll forego that so long as I've got improvement of hemodynamics and overall improvement of alignment, understanding that this probably isn't my definitive fixation at the time that we're doing this.
So I think what I heard you say is anterior frame has a lot of trouble controlling the back of the pelvis, right? And a sheet does a much better job of doing that.
I think so. I think so.
I would totally agree with that. There's a question, and we're going to get to that question about pelvic packing. What I did in this particular situation was place supraacetabular pins and then use the distractor as a compressor with sort of fixed struts. I put the pins back, pretty quickly because things were moving pretty rapidly here. There wasn't a lot of time for us to do, in this case, resuscitative screws. There was a lot of concern for just moving him out of the operating room. So my thought was to get my pins into as far of the posterior pelvis as I felt comfortable getting them, and the angle of certainly that one is towards the greater sciatic notch. It's about as far as we could go, but using those pins fixed in that angle and using the distractor as a compressor, we were able to close the pelvic ring down somewhat. Nice. So still a little bit wide in the back, better in the front. And as you can see, we did do some pelvic packing. So are either of you guys doing pelvic packing in your institutions? And if so, when? And do you find it to be an effective maneuver?
We don't routinely do it at Kentucky, and I think we favor more so selective angiography when indicated instead of. And the reason, at least my reasoning here, is that I think, frankly, it's hard to communicate to our general surgeons that packing alone is insufficient, meaning that you have to have something to stabilize the ring, as you've done here. This is a great time to do packing once you've done some stability, but I think it's hard to convey to our general surgery colleagues that you can pack all day an unstable pelvic ring injury and it won't do much. What has to happen is you have to have some stability imparted to that unstable ring for packing to be effective, and it's been like a 20-year tradition of misunderstanding here, and so we don't do it.
Understood. Yeah. You can't just pack into an open door, right? It's just going to keep going out the door. Yeah. You can see this pin's working quite a bit, and I'm sure if we had an axial view of the other pin, it's also working. Are either of you, maybe Steve, maybe you can answer the question, any role for C-clamp in this situation? It seems like maybe this is, if there ever going to be an indication for a C-clamp, this might be it.
Yeah, I think that's certainly talked about for injuries like this with complete bilateral injuries. But I think, as Dr. Wright was mentioning, I think the technique for placement is critical for that. And if you're going to go through the kind of precise placement of those pins through the C-clamp, putting in direct cannulated screws for the posterior ring, I think is as effective and possibly more stable and less cumbersome to the patient and the recessive measures. And so I think if you're going to go through putting pins into the posterior ilium, I think placing a resuscitative screws would be the way to go, but certainly I think an option at some institutions.
Yeah, you got to have it, right? You got to have a C-clamp to actually do it. We don't have one in our institution for all of those reasons, mostly because we're facile with screws. Despite this, he's still having trouble. He's got more blood, more factors, and he remains coagulopathic. And so I don't want to belabor this case too much, but he now goes to angiography where remarkably, they don't find any active extravasation, but lots of spasm where you'd expect them in the posterior part of the pelvis, right? And so as is not uncommon, I think, in all of our institutions, they have to do something. And so this non-selective gel foam embolization of both of those vessels is performed here with the presumption that they're in spasm because they've been bleeding all this time, and that they will find their way to the end divided vessels and create some sort of hemorrhage control. Steve, do you see that much in your institution? And if so, do you see any complications from that?
Yeah, no, I think certainly non-selective embolization is done when they don't see a clear source of bleeding in a hemodynamically unstable patient with a pelvic fracture. But that being said, I haven't seen complications from that here yet, but I'm sure that that's coming. But certainly, I think, again, going to the thing that you mentioned at the introduction, life limb function, if it can save their life by doing some embolization and minimizing hemorrhage, I think potentially the detriment to their overall function long term is worth it.
It would never be something that you'd administer to someone whose hemodynamics were stable, but in this case, it certainly seems like a reasonable thing to consider doing. So that's what happened here, and not surprisingly, actually, his hemodynamics did improve afterwards. Look, I'll move through this one a little bit. Here is what we did at day 7, and what I heard both Steve and Ray say is that you should have done this on day 1, on day 0, is put a couple of these resuscitative screws in to get control of the posterior part of that pelvic ring, because it does a much better job than any anterior frame can do. So certainly, if I were to do this case over again, I would do as they suggested and try to convince my colleagues that I could get a couple iliosacral screws, just means one on each side, really, to close both of the posterior sides of the pelvis down. I think probably would have helped this guy on day 1 rather than on day 7. Now, even so, looking at these, he's not perfectly reduced. I guess the downside of that is that it's not perfectly reduced, and he may have some pain in his posterior part of his pelvis. That the upside, obviously, is that he's alive. And so I think, to summarize, we'll accept some of these malreductions in these specific situations simply because we're doing it for hemodynamic and resuscitative purposes. Is that fair to say, guys?
I think it's a very fair statement, and these things, these kind of injuries too, it's happened on occasion where you've got a subtle extension deformity, of one hemipelvis versus the other, and gosh, if you get him stabilized and you've got a scan that demonstrates what you're seeing here, and I think this is the time to have a talk with that patient once they're out of that critical hemodynamic ARDS sort of phase of their care, and it's not wrong to take him back to an open reduction, take out his left-sided sacroiliac or iliosacral screws, and then do an open reduction of that symphysis with the hope of, or with the thought that would line up his posterior ring a little better and target it with another percutaneous strategy or open strategy. So I don't think that's wrong. That doesn't happen very often, but I think that's a possibility too.
Absolutely agree. Unfortunately for this gentleman, he did poorly, as many of these folks do. I'd like to relate it to just his initial management. I think he got so resuscitated. He had a stroke. With time, he got ischemic bowel from having his guts in a bag for so long, had a long bout with ARDS, and eventually succumbed when care was withdrawn. So anyway, some lessons learned there. I mean, the point of this case is to consider earlier sheeting and probably early posterior ring fixation in an effort to acquire a proper resuscitation in this patient with primarily, an isolated pelvic ring injury, though, remarkably unstable, still was the main injury here. So thanks for taking us through that. I want to take it through. Maybe I think I may want to go through a different one. Let's go back. Let's do this guy right here. So this guy is about my age guy who was finishing up his helicopter training, doing sort of takeoff, touchdown was his last day before he got his license. And well, it was his last day in the as you can see in the helicopter too. He had a significant crash, and when the emergency personnel found him in the helicopter, he was in this position called the scorpion position. My kids know that when they go inner tubing on the lake. the scorpion. They always get really excited when they do the scorpion. And beside that, he was pretty sick, hypotensive, didn't really respond to any sort of fluid en route. And ironically, he was airlifted to our facility. For those of you who don't know what the scorpion position is, that's the position that he was in the compartment. And both of his femurs were sticking out through his legs. So he's pretty sick. He's a polytrauma patient, right? He's hypotensive, he's tachycardic. The team has already intubated him, and he's got these sort of complex open wounds through which his femurs were previously sticking out. Both of his lower extremities have diminished pulses. He's anemic already, which is a little unusual. That means he's lost a lot of blood, right? Because he just showed up, and he's got an elevated lactate. He's got a pneumothorax with lots of rib fractures, and the team put him in a binder in the field, but no fracture in his pelvis was identified. So we do have these X-rays. While they're getting these X-rays, a massive transfusion protocol was started because he had been bleeding quite a bit for a while. He got a chest tube to decompress his tension pneumothorax, and interestingly, his vital signs responded significantly. The orthopedic team, straightened out his legs and his pulses returned, and he's got these injuries: so bilateral open femurs, a displaced talar neck. Woe was him. And what are the priorities here, Steve? What should we be thinking about here in this guy? He's still pretty sick. His vitals have improved somewhat now that he's got a chest tube, but what do you? This maybe is too simple. How does your algorithm help us in what to do with this guy at this point?
Yeah, I think in this guy, everything is pointing towards doing a damage control initial operation for him, given his persistent hemodynamic instability, as well as his severely open injuries and unstable injuries as well. And I think, the combination of the femur fractures with the particular injuries distally, definitive fixation for him is going to be a bit more than a simple femoral nail. So I think debridement irrigations and provisional external fixators will be the initial operation for him to minimize his, sepsis down the road, as well as provide skeletal stabilization for his long bone injuries.
Yeah, so these guys' femurs kind of make it easy, right? So, he's got bilateral common interarticular fractures. It's not likely that this guy you're going to start trying to put those guys back together on day one. His clinical status does improve. He gets some more blood, and his trend, as you can see here, is hematocrit improves, his lactate decreases, his gas is good, and so, as you said, what now? Wash out, frame, and live to fight another day. What if these were his femurs, Steve? Would that change what you did?
I think it makes you think a bit more about definitive fixation. That being said, I think considering his situation, especially with all the parameters you mentioned, with his initial lactate, his hemoglobin, which is required, multiple rounds of transfusion. I think for this debridement irrigation and still external fixer, again, come back and fight another day once he gets further resuscitated for him. But I think it makes you think a bit more about possibly fixing one fracture. But that being said, still, with segmental comminution like this, some thought, needs to be there in terms of the definitive fixation for each of these fractures.
It's a little tempting, right? Like you kind of want to get started, and I know I can make them better by at least getting one of these fixed, if not both. Is there any risk to nailing both femurs in a polytrauma patient? Let's just take it out of this. This guy is I think we all agree is pretty sick, but say a patient that otherwise has normal hemodynamics but comes in with bilateral femur fractures. Are there any? Is there any guidance? I know that some of these folks can get pretty sick after having two reamed femurs fill up their lungs. Is that a real thing?
Yeah, I think it's for sure real. And I think this goes back to something we've mentioned multiple times is communication with the rest of the care team is really important. So I think very much depends on the clinical situation, but discussion with anesthesia intraoperatively during and after the first femoral nailing and discussing the patient's pulmonary status is important. And I think doing both at the same time is definitely possible with the ideal situation. But that being said, I think playing the safe side of nailing one, X-fixing the other to minimize those complications is also a very reasonable possibility.
It's one of those things that's really hard to study, right? There's not that many cases of people coming in with both femurs that come in that are well enough to get them both nailed at the same time. And so safety, certainly we all have stories where, you know, those people get them both nailed and then they turn out to do poorly. And we all obviously all want to avoid those sorts of situations. But as you said, constant communication, reevaluation, especially in this case with the anesthesia team during surgery, is probably most important. So back to our original patient, how'd we do? More importantly, what did we forget? We got frames on, or out to length for the most part. There's big spaces in between. This was done on the weekend, and our guys sort of just kind of forgot to put antibiotic impregnated cement, antibiotic eluting cement spacers inside there. So don't forget that your job is to reduce the risk of infection in addition to getting antibiotics on board early. Filling up that dead space with antibiotics is really helpful, especially when the dead spaces are that large. And so remember, those areas are poorly perfused, right? They've been stripped, and so the blood flow to those areas, although they fill up with blood, they don't have great perfusion to them. And so antibiotics, if you deliver them peripherally, may not work very well in those big dead spaces. And so local delivery of antibiotics via cement beads can be a really effective way to reduce the risk of infection. So here he is post-injury day 2, and he looks pretty good, Steve. I don't know what some of those numbers mean, but base excess seems like it's good. His plate is not coagulopathic. It's only day 2 though. So, you know, to my original question, is it safe to bring this guy to the OR to start working on these?
Yeah, that's when we get our interns who are recently, you know, gone through medical school to explain a bit of this physiology. But I think certainly, you know, a repeat debridement and then placement of some sort of antibiotic local delivery mechanism would be good in him at this point on post-injury day 2.
Good, yeah. So that's what we did. He tolerated a lot of surgery that day, and it was because our colleagues in the general surgery group really did a great job resuscitating him on day 1. And so this is sort of what he had, you know, about probably 6 hours worth of surgery on day 2, but he tolerated it just fine. And he actually turned around real quick and was awake on day 3, and you know, wondering when he could go out and fly again. It did take a while for us to get him back into the air, and he needed some pretty complex reconstructions to get these things fixed. So this is just sort of a tease for those of you that are interested in this sort of thing. You're all fellows, and you're all obviously interested in orthopedic trauma. So I encourage you, if you can, to go online and watch the osteotomy courses, the bone defect courses that we have online, because the way that we manage this can be, you can learn a lot more about it either in our live courses coming up or even in old recorded webinars. So just a little taste. I want to finish with one final case because I think it sort of demonstrates some good teamwork that I think really ended up saving this person's a lot of misery for this individual. So this gal is a 23-year-old who was graduated from her nursing school just earlier in the day, and of course, like most people do after graduation, went out and enjoyed herself with some friends, but unfortunately it ended poorly, and she was ejected from this vehicle after it rolled over. She had lower extremity deformity and severe pelvic pain. The EMS folks brought her to our emergency room, and she was, again, tachycardic, hypotensive, with what you'd expect sometimes, a sort of normal looking hematocrit in someone who's not yet really exsanguinated. And so these are our initial films. Steve, any other labs that you want in this particular person? We talked about lactate. Is that something that you want to get right away? Are there any other laboratory values that you think are important here to determine sort of what the next steps or what she can tolerate from an orthopedic standpoint once she gets to the operating room?
Yeah, I think lactate initially is a great indication of her end organ perfusion and tissue perfusion, and a marker of her resuscitation. And that gives you a baseline value that you can then, again, reassess over the course of her resuscitation. So I think certainly a lactate would be helpful in this scenario to help track her resuscitation and see where she's starting from.
Okay. Ray, is this a good pelvis for a binder? Should we put a binder or a sheet on this guy?
You know, I can't think of too many bad pelvic fractures for a binder. You know, I don't know that there's too many bad ones. Now, outwardly by this image, I don't see a whole lot of ring opening, but I don't think it's ever wrong. If you have instability and it takes no time as a temporizing measure, if you're getting patient ready for other studies or whatever the next phase of her care is, if there's concern of hemodynamic stability, there's a potential unstable pelvic ring, I never think that it's wrong. But like we pointed out before, examine these patients before you wrap them up.
Sheet or binder, is one better than the other in this particular case?
Sheets better for me because there's bed sheets everywhere in our hospital, you know, and I think most of us would consider them tantamount to the other. There are some pro binder folks that say that you can put on a binder by yourself and it's easier to maybe to cinch them down than a sheet, but I don't think it's that hard, you know. So
okay.
I like sheets because you can cut portals in them too, and binders it's harder on your trauma shears to do that.
I think sometimes binders could do a little too much work.
Yeah.
Sometimes you can almost overdo them. Additional physical examination on this gal, as Ray suggested with our first patient, you know, put your fingers in the holes that need to be examined. And in this case, she's got bleeding coming from her vagina, and she's got a big degloving wound that is closed on her left thigh. Despite the bleeding coming from the vagina, it looked like her urethra was okay to cannulate. And so the team did stick a Foley catheter into her urethra, but immediately got bloody return. At this stage, her vital signs have improved after a couple units of crystalloid and 1 unit of blood. The patient did have a binder applied, and although this isn't a picture of her, this is a picture of a patient with a lateral compression injury with a binder. And I think it's hard to make this happen in a sheet, because you really have to crank the heck out of the sheet to make this happen. But I think it's easy to do this with a binder. So my personal opinion, like yours, Ray, is that a sheet is a better tool because you can't overdo it. And although this probably didn't hurt this person, it probably did make her feel a lot less comfortable than she otherwise could have felt.
Yep.
So the patient goes to the angiography suite, and we confirm what appears to be a lateral compression injury, but a really deformed anterior ring. Look at the ring here in the front. It's really pretty crooked, right? It's not right. It's really squinched. And this is when she has a binder on. You can see the binder on the CT scan. And so this may also be a case where perhaps the binder is causing over compression of the anterior part of the ring. It is an angiogram, and she has no evidence of extravasation. In addition to the parasymphyseal fractures in the front of the ring, they don't see any extravasation elsewhere, which is good for her. She does, because she has blood in her Foley, undergo a retrograde urethragram. And if you can see these images, you see 2 densities. There's one with that appears to be adjacent to the Foley, and then one that appears to be in the bladder. The bladder's filling up, there it is, but there's also contrast aside from the bladder, which essentially represents a urethral injury. So the Foley catheter is through the most distal part of the urethra and then just into the true pelvis, but not into the bladder. So she's got a urethral transection, and urology wants to place a cystostomy tube. She's got that injury. So her orthopedic injuries are this unstable anterior and posterior ring injury. She's got open wounds in her vagina that communicate with these anterior ring fractures. She's got a closed displaced subtroch fracture of her femur and a big thigh degloving. Sort of running out of time here. Priorities, Steve. What are you thinking? She's got this urethral transection, right? So her orthopedic injuries are there, but then you've got to work with the urologists who want to put a cystostomy tube in her. What do you think? What are your priorities here?
Yeah, I think the unstable pelvic ring would be high on that priority list, and depending on what the urologists are going to do with regards to if they're going to do an open approach or some sort of percutaneous procedure. I think if they do an open approach, it's nice to be able to work with them through their approach, do some sort of reduction and fixation of that pelvic ring injury as well in conjunction with them. And then for me, I think femur would be a secondary priority after the pelvis is reduced and stabilized.
Think any other thoughts, Ray?
Yeah, I think it's really interesting when you see that displacement of the bladder, and we're likely seeing that due to the retrograde urethragram that was done. But sometimes you can see, if you're careful and you're picking up on these soft tissue things, you can see that kind of displacement just from blood. I think it's kind of hard to tell. You were there, but it's hard to tell. But every now and then you'll see, even in these so-called lateral compression injuries, these patients will lacerate right through a corona mortis or some other big vessel that'll just bleed and bleed and bleed. And lateral compression fractures can be hemodynamic instability makers too. And you can see a bladder that looks like that. I was just thinking of a patient not too long ago that we saw with a contrasted just like that. But I tried to, if at all possible, this is another having a discussion with your urologic colleagues, and sometimes I have a certain amount of clinical disdain for percutaneously placed suprapubic cystostomy tubes, in as much as like the infection rate is like 317% after they have one of these. And so in fellowship, we had the luxury of having people that would do an open exposure, and they would do an antegrade cannulation, but that's work, and it's hard to get people to do work sometimes, but sometimes having a discussion about this is good. Now, in general, it seems to me if you're planning on some percutaneous fixation, sometimes that you can do that pretty safely with minimal risk of infection. But it seems to me that at any time a tube goes percutaneous right into the bladder, that your setup for infection is great. And so this is a complicated fixation problem, and I think decisions made night of can really affect your outcome long term.
Boy, yeah. I mean, you've been here, you've seen this, right? So you know how this is going to go. And fortunately, because of that communication, it actually turned out okay for her. So Steve already stated the priorities: open fractures, pelvis is going to kill her, then the femur, and then the GU injury from my standpoint. But how do you sequence these things? And we did it a little bit unusual, because in my discussion with the urologist, they said, we got to put her in lithotomy, because we got to try to look, retrograde up her urethra to try to, realign the other end of her urethra. So, what about putting her in lithotomy with the femur? And I said, well, we could fix the femur real quick, and then we can work together on her pelvis. They said, all right, let's do it. So this is a little bit of a funny sequence, right? We fixed her femur first, which was not her worst injury, but it made us be able to safely put her then into the lithotomy position, where they tried to put her retrograde cystoscope in, and then a flexible scope, and still couldn't pass it. And so we looked at each other and said, I know that I can help you here if you just let me reduce the front of the ring. And so together we did a fan and steel exposure, and they were kind of surprised because they'd never really done it before. And just by reducing this ramus here and turning it into a ramus that looked like this, it lined up the urethra once again so that they could pass the cystoscope, identify that there was no injury to the bladder. It was simply a urethral transection. And then all she needed was a Foley. That's all she needed. And then we fixed her posterior pelvic ring and put a frame on the front, washed out her wounds. You never want to be that guy who's washing out wounds with a patient in the lithotomy position, but there I am doing it. But I still didn't want to put a frame on the front because of the open fracture wounds, but she went on to heal the front of her ring, with reasonable alignment. Her femur was never an issue. And most importantly, she had her catheter removed at about 6 weeks and was voiding normal. And so again, sort of the priorities we can identify, but they don't always perfectly translate into the sequence of how you're going to fix them. And they became a little bit different in terms of their order because of the communication with the adjacent services with whom we work. And I think it saved this lady a lot of urologic misery in her recovery phase.
That's really a great case, man. I think that's damn near heroic, the effort. I mean, and the communication, just in as much as I think a lot of people would be like, yeah, screw it, let them put in their tube and I'll get after it later. But she 23-year-old gal, and it just we I think sometimes scoff at things that are not bones. The long-term outcome stuff. Urologic issues. That's the kind of stuff that's life-altering things. That once they live and once they heal, they're things that can plague them for their entire lives. And so that's you're my hero. Warner's your hero. Now you're my hero. And so this is great.
Yeah. Well, I mean, I think that you can take those examples and put them all over the body, right? I mean, we talked about the traumatic brain injury, the closed head injuries, right? I mean, we can make those things better by fixing long bones as long as we communicate with our colleagues. And it's been said enough ad nauseum here, but communication, I think, is the best way to help optimize the care of our patients. And just as you said, in the world of epic chat and texting, picking up the phone or just walking down the hall and knocking on someone's office door, that really goes a long way. So we're about out of time. Are there any other questions from the audience members who are still on? Really appreciate you guys sticking with us. I hit the wrong button. So I'm going to go back and go forward and then hit my summary slides. I apologize for that. So again, remember the priorities of what we're all trained to do: first life, and then limb, and then disability. And sometimes that means an imperfect posterior ring reduction to save a life. And as Dr. Wright said, we can always come back and fix that later. Remember, we just talked about this. We're part of a team, and the more you know the team, the better off your patients are going to be. Be involved. You're the expert, and you can help educate the members of that team, whether they be the neurosurgeons or the general surgeons. Certainly, I learn a lot from them, and I don't hesitate to teach them about what I know about orthopedics. Consider using an algorithm to help sort out complicated polytrauma patient care. Don't hang your hat on any one number. As Steve taught us, trends are helpful, and constant reevaluation for our polytrauma patients help us get them optimal recovery. And then, as I think I showed you in the 3, and I could have shown you more cases, we all make mistakes, and sometimes, they stick with us for a while. But it's helpful to learn from those mistakes. Be critical of yourself. Look in the mirror. That's the only way that you get better at what you do. And I hope that you all want to get better. I certainly, at age 52, I'm still getting better because I'm learning more. And the more I see, the better I get. But I won't get better if I don't look in the mirror. So I just encourage you guys to think about that. Learn from, it's great to do a great job. It's great to do that last case and feel good about it. But it's even better if you can learn from the things that don't go so well. So with that, I want to invite you to a couple upcoming webinars throughout the year. We've got both trauma webinars and fellows webinars. The next one coming up in March 8th by Dr. George Dyer, my friend down in Boston, who's going to talk about shoulder arthroplasty. And then a week later, our buddy Chris McAndrew from St. Louis is going to talk about femoral necks. I bet he'll show some good cases. I want to thank my good friends, my colleagues, my buddies. I can't wait to be able to soon see them in person at a real course. Thanks, Raymond, and thanks, Steve. Really appreciate your guys contributing tonight. I learned a lot from both of you guys. For those of you that are still on the call, I want you to just stay on until the very end. It'll just be another minute to answer the evaluation and poll questions at the end of the webinar. And then finally, I'll thank you guys for sticking with us. Appreciate your attention. And I wish you guys a good rest of your year as fellows. Hope to see you in March at the fellows course.